It's really my privilege to moderate for two reasons. One is I don't have to do any of the work. These gentlemen, and soon you'll be seeing Laura Landry, they're going to really share with you their wisdom, which is just phenomenal. So today you get to have in the next hour a free consulting session. So be sure to ask any question you want. These should be some of the most highest paid experts in the field. So this is your opportunity to have direct access to their experience in free consulting right now. What we thought we'd do with our format today is not go through the typical long-standing PowerPoint presentations, but really have a dialogue with the folks who are here, who will be speaking about their experiences and answer some of the questions that you might have. I have a few questions of my own to pose with them. One of the things that I wanted to do is, first of all, to thank Jose, I think he's still in the room, for putting together this panel. This is really a group of leaders across the country that you won't see anywhere else. As Ken Kaiser alluded to, California is really not like the rest of the states. We don't have a state HIE that everyone's extremely clear on, and we know you either plug in or you don't. Instead, we have a wealth of experience from individuals like those that are here today. Laura Landry is going to be leading off our session as soon as she arrives, giving us the background and her experience as a pioneer in health information exchange, where she really started many, many years ago, focused on the population health care delivery issues here in the urban setting in Southern California, and was one of the leaders in innovation around health information exchange. After that, I'm going to ask Will Ross to give some leadership. Will is a national leader in standards development, in technology, in responding to and developing technical solutions, and then carrying those out, not in a really easy setting where there's lots of money and ease of access, but not only has he developed some of these key technology capabilities and strategies, he's developed them to serve the safety net and rural marketplace. And then summing things up will be Rich Swafford. He has taken the leadership of really one of the most exploding and nascent HIEs in the country. He'll tell you some of the statistics, but he and I are both really proud of the work that's being done in the Inland Empire as community providers and stakeholders come together to bring their information about patients to really change the way that healthcare is delivered in the Inland Empire. And then he'll talk about some of the other work that he's doing to expand that. So one of the things that I wanted to do was really offer the opportunity to have you ask questions to the group. So we'll spend a few minutes working on some of the foundational information and stage setting, making sure we're all talking about the same things in HIE. And the first thing we're going to do is call Laura.
Perfect.
Can everyone hear Laura?
So I apologize for not being able to be there right now, and it will be quieter in just a moment when I pull off the freeway. But I am really grateful for the opportunity to talk to you about what I really think is the perspective. I have been participating with Health Information Exchange since 2003, and I actually made an active decision to step away from it for 6 months so that I could get my perspective back. And one of the things that it gives me a real thrill to be able to do as I talk to you about this is I can actually now look at what got accomplished and what didn't work and how it works in a perspective that is different than I was able to look at it when I was actually fully engaged as an executive director or a CEO in an organization whose job was to make health information exchange work in large metropolitan or a large state area. So my theme for today's talk is, as I was thinking through the things that interested me about how health information exchange is working, I actually had the opportunity to think about the theme themes of health information exchange in a very similar way to the themes of once and future king. So it always gives me a thrill to be able to talk about medieval England and compare it to 21st century healthcare and healthcare information technology. So if we can move to the correlated themes slide, Corey. So in Once and Future King, we have these themes that Arthur's a political innovator, there's a relationship between strength and justice, and it constantly got tensions flowing throughout it. Civilization can be undone by internal tensions and treachery. And if you look at health information exchange, there are some very similar, well, they're not similar, but there's three very strong themes as well. There's data movement as a medical innovator. There's a relationship that has tension in it between privacy and saving lives. And health information exchange can be undone by competitive tension and regulatory ambiguity. Let's move to the next slide. So there are myths and legends that I think you can correlate between Once and Future King and Once and Future Health Information Exchange. Let me pause for a second. The thing that makes it Once and Future that I was so intrigued by is there really is this ebb and flow of things that work, things that are innovative and don't work because society isn't ready for them or the conditions for making them work aren't quite right yet. But the act of talking about it, the act of taking action around new ideas actually makes it possible for society and specifically healthcare to move forward around health information exchange. And that's why I really chose the Once and Future HIE as the theme for this talk. So in myths and legends, there's, in Camelot we've got the perfect setting and it will bring about perfect peace. And the Round Table says that, removing all visible signs of rank will reduce conflict. And then, of course, there's the Holy Grail, which symbolizes what you can only get once everything is perfect and things are going exactly the way they should get. And, of course, everybody fails to achieve exactly what it is that they wanted to achieve. So in healthcare and health information exchange, we have standards and we have myths that a perfect standard, whether it's a transport or content standard, will bring about a perfect data movement environment. We had a myth that funding, $200 million across the nation, will bring about the ability to make health information exchange work in a perfect environment and get it moving and actually bring about the tipping point, the one and only tipping point. Maybe I should have made that the one and only tipping point as the myth and legend. And then there's also the myth about the right thing, that people and organizations will prioritize tactics and funding to save lives and improve outcomes in a vacuum, and that nothing else will be discussed. But they'll just do it because it's the right thing to do. And then my third and final slide on this particular version of this topic is correlated lessons learned. And I think this is really, really important. In Once and Future King, Arthur learned why the world lags and why the world lags and what lags it. And we learned that predators can do unimagined damage, and that society ideas that don't work well will return when society will either accept or demand them. And we also learned that first-hand experience is priceless in opening up our view about how other people think about things and how we can think about things. In health information exchange, I think we've learned a lot about what motivates healthcare stakeholders. And it's complex. It's not simple. It's not simplistic. You can't say, if I do this one thing, then that will solve the problem. There's no one thing that's going to solve the problem. We've learned that well-intentioned people can do unimagined damage. Not for any purpose to do unimagined damage. In fact, with the best purposes of the world. But if you don't know what it is that it needs to get done, and you say, this is what needs to get done, and it distracts people from getting that thing done, it takes a lot of the energy away from what could actually happen. there is a demand for integrating patients and providers in more health information technology and exchange mature organizations. So the farther you get along the adoption curve, the more demand there is for integration. That's really important to know. It tells us what are the likely targets for us to work with. We also know more about the mechanics of health information exchange across organizations. We had a lot of theories about what it would and wouldn't work back in 2003, and Bill Behe in Santa Cruz had theories about what would work back in 1994. We actually know a lot more about what works and what doesn't work. So those are kind of the historic lessons that I've learned, and I hope other people agree that these are the lessons we have learned. And what I'd like to do now is talk a little bit about 2013 and beyond. As a health information exchange, recovering health information exchange operator, it's really important that I say we need to bust a particular method myth called the health information exchange urban legend. There really is no one true way to do that. As in the example of medieval England and Arthur, right now the conditions are not right for mass change. The conditions are right for change and progressive change, but not mass change. And then the other thing that's important about this is the one true way legend, is that there is a variation in healthcare logistics within and across regions, and those are legitimate barriers to systemization. And by the way, regional variation is very important. You wouldn't necessarily want to have the same plan for health information exchange, how you operate it, how you do it, how you roll it out for Los Angeles, California, as you do for Santa Cruz, California, or for, Riverside, even though the demographics are relatively close in many ways. Next slide, please, the ground we've taken. So, today, in 2013, moving health data is a viable, thriving business. I can guarantee you it was not a viable, thriving business in 2003. We have new vendors developing new products that think about things differently. We have existing vendors who are the feeder system, and the feeder products, like the EHRs, are making changes to accommodate HIE, and they're innovating in a way they've never innovated around data movement. We also have organizations that have seen the opportunity for health information exchange investment, creating competitive advantage. So the organizations are starting to go, wait, I need to do health information exchange. And what we're seeing, which is very appropriate, is those organizations make the connections for their business goals, the things that actually, bring their revenue in and pay their bills and allow them to pay the people who work for them. They prioritize those above connecting to the community for the most part, and that's completely appropriate. But once they've gotten connected for their own business goal, they tend to expand into the external networks like the Nationwide Health Information Network or Direct Exchange or their local community organization. So that's a lot of very positive movement in the right direction. The next slide, please, is Lori. So the environment we have community health information exchange enterprises. Those are organizations whose entire mission and purpose and business plan are focused on connecting the communities they're in so that they can exchange data. And they're solving community-wide problems. And most of those organizations that have survived have modified their business plans in a way that allows them to prioritize meeting their customers' goals first, and then meeting the community goals. So they've evolved from, we need to do the social good first and then help you solve your business problem too. We're going to help you solve your business problem, and that will help us meet the social good. Then there's also the enterprise HIEs, and these have all evolved to meet regulatory or business goals, and many of them are extremely mature. And in fact, many of those very mature efforts have been at the forefront of creating the ability to have those internal health information exchanges look at connecting into the community infrastructures and the national infrastructures, and they're starting and have been driving the standards to support that. So if we really look at what is the determining factor, next slide, sorry, Lori, on whether or not health information exchange moves forward with any individual organization or in any community, the determining factor really is the maturity of the health information technology operation, not necessarily the maturity of the health information technology used, but the back-end operations, people who actually make the technology work. So it's an organization that understands its data challenges, it understands its mapping challenges, it understands where it needs to move data to and why it needs to move it. And it understands that it has limitations. Several of my former organizations' first clients were people who said, look, I can maintain 10 or maybe even 100 interfaces, but I can't maintain an interface to every one of the 1,500 doctor's offices that we have. I just can't do that. And I know I can't do that, so I'm looking at the community information exchange to be able to do that for me. That's the kind of organization that's going to be able to participate robustly in a health information exchange. It's also the story that the health information exchanges at the community level are going to their partners and saying, you don't have the ability to scale this. It doesn't make sense for your business model. It is our business model. Let us do that for you. And then finally, I want to talk a little bit about today's health information exchange service provider, and that's the next slide. So the characteristics of today's health information exchange service provider are very business-oriented. You're going to start to see this is a business that we're in. And they meet the customer's priorities. Back when I started health information exchanges, we were talking about how we were going to solve the problem and save lives. And that was all very good stuff, and it was very well intentioned. And we had to learn that saving lives is people's business, and there's a priority in infrastructure. There's only so many dollars, and they can only be spent in so many ways, and there's only so many things that you can do in a given year's budget. So aligning today's HIE service provider aligns itself to meet the customer's priorities. It offers the relevant services for its customers. The other thing that it does is it provides expertise. It provides consulting for an organization that doesn't necessarily know what the next steps are. And it has a replicable implementation model. It's something that they can say, Hospital A, here's how you install and operate your interfaces, and here's how you participate. And here's the policy language you have to add into your privacy and security policy. And here are the things you need to add. So they're a value-added partner. They're an expert in helping their partners move data. The next point is that they provide a business class service. So some of the HIEs are still on a roadmap to provide, disaster recovery service, but they're all keenly aware and they all have strategies for making sure that they have disaster recovery. But the successful HIE service provider has mature operations and they're understood and they're written down and they can train a new person for scaling. They also have a viable roadmap for sustainability. They may not be sustainable today, but they're on track and they're making their goals, and they will be sustainable as they make their goals. And then the other really important thing about today's service provider is they're a growing, thriving business that's always looking for their services to be relevant and expanding to the people that they're providing services to. And I know that this is a really good lead-in for when we move to what Rich and what Will are saying, because they exemplify what today's health information exchange service provider is doing.
Great. Thank you, Laura. We appreciate that, and we appreciate the audience. You should see the faces of the latecomers who wondered how I'm doing ventriloquism. We'll see you shortly.
Hi, I'm Will Ross. I'm the project manager for Redwood MedNet. We're a health information exchange service in Northern California, north of the San Francisco Bay Area. I'm going to cover 4 quick steps. A little overview of Redwood MedNet as a business, a little overview of our approach to technology, and then some considerations on how we got here and what our next steps are. And I mean by we, I mean health information exchange in California and nationally. So briefly, Redwood MedNet provides clinical data interoperability services to a number of healthcare facilities in the North Coast region. Most of our services happen to be in Sonoma County, but we also serve healthcare facilities in neighboring counties as well. This is map's actually a little bit older. This was made in November, so it shows some new. The yellow dots are the new ones that were in development at that time, and I haven't updated this map yet, but we will be issuing a new map in a couple of months. As a business, Redwood MedNet was formed out of a community steering committee that originated. There were actually 2 groups that were talking simultaneously. It was a steering committee at the Public Health Department in Mendocino County and a steering committee at the Mendocino Lake Medical Society. And we incorporated in 2005. We have a 9-member board of directors. Most of our data traffic is lab results. The second most common form of traffic on our network is immunization reporting. And I wanted to mention that conceptually as a business, Redwood MedNet sees itself in the supply chain provisioning business in the middle of a complex adaptive system, as Dr. Kaiser was alluding to. It's not as easy as picking up something off the shelf and shipping widgets. This is actually a little more complicated. In terms of our technology, I'm just mentioning a couple of highlights of what we use. We have a Connect Gateway service on the eHealth Exchange. We have a transactional approach to data transport. We are not focused on building a longitudinal community repository, because in our neighborhood of California, there are too many enterprises that would not contribute all of their data to a longitudinal repository. We're interested in accelerating the transport, the movement, the interoperability, the, as they say, the liquidity of the data. We want the right data to get to the right place at the right time. And that doesn't mean that the provider has to log into our portal. That means that we can insert the data in the application that the provider is looking in, that's in their workflow. We have so in other words, instead of having a giant community clinical data repository, we have a co-tenanted approach to edge proxy repositories. And we also are standing up some secure nodes because what we're finding in a lot of cases is the focus of Redwood MedNet has traditionally been on the technology challenged, resource limited, or underserved facilities in our region. And in a lot of cases, we have a facility that has an incentive to adopt electronic health records. And so there's a budget, and there's no one on IT at that facility. And it's not going to be a pretty picture if we don't adapt to the level of technology that is going to be successful at that community. So we've been working on that. This is just a quick overview of what our interface dashboard looks like. It's a little bit old, but it's on the left there are channels, individual channels that are running filter and transform actions on clinical messages that are in transit. And this is part of what it looks like to us when we're managing the traffic on a day-to-day basis. This is a picture of what we're currently working with as our small form factor device to resolve some of the technology challenges that limited resource facilities have. This is it's actually a little, I should have brought one with me. It's the size of a paperback book. It's a development environment. And what we've done is we've installed a particular stack of software on it so that it can be a secure endpoint, a file server, a member of the local file system. It can print locally, and it gives us really excellent staging opportunities for facilities that have, it might be what I would call a ma and pa practice, where there's the doctor, the spouse is the practice administrator. There are 3 desktop computers in the practice, and one of them is pretending to be a server. And it's the kind of environment where this type of assist gives us tremendous flexibility in integrating bidirectional clinical messaging with the practice's EHR. I have just a couple more things about technology. The importance of the HIE Ready program that CHEC is pushing can't be overstated. I'm going to get into it in just a sec, but we are really suffering from some structural business impediments to the procurement of interfaces because of pricing models that are left over from a legacy environment never intended to support broad interoperability. So we've been trying to help that process along as much as we can. The question I want to propose is I'm really looking forward to finding out the answer to this question. Will there be robust adoption of meaningful use stage 2, or was stage 1 the high water mark? I'm looking forward to seeing the answer to that. I think it's an open question. And there have been a couple of new initiatives that have shown up lately that I think are worth watching. One of them is directtrust.org, and another is the Commonwealth initiative that was announced at HIMSS just last month. So how did we get here? This is the little overview I want you to take away from my talk. I'm going to mention 4 papers that are reference points for this theme. The first one is that there was a lot of development work done in the early part of last decade on the importance of adding health information technology to healthcare in order to achieve a return on investment and improve quality of care. There's the whole rise of IHI and the AAA movement. Some really excellent work that's been done on the systems side of how to apply healthcare to the problem, the cost problem in health IT, the cost inefficiency and quality problem. So we led off with a major study done by Partners Healthcare, published by HIMSS in 2004, that drilled down into the nuts and bolts of where the savings could be achieved. This is a 170-page book you can get from HIMSS. It's a little bit out of date now because that was some pretty creative analysis and modeling. This was followed up by a RAND study that came up with pegged a number of, this is 2005, we're talking about $80 billion a year we will save from the introduction of health information technology. Okay, well, cutting to the chase, it's 2013, billions have been spent. And RAND, in January of this year, published an update. They revisited their study 7 years later. And mysteriously, the healthcare business sector has grown by about $800 billion, and we haven't seen this return on investment yet. The primary observations of this particular study from RAND are that A, the adoption of health IT is below the level they were forecasting that would be necessary for the ROI. 2, the EHRs that are being installed are legacy product that are neither interoperable nor easy to use. So there's some resistance to their adoption in the trenches. And 3, remembering what Dr. Kaiser said earlier today about applying technology to a disorganized process, it's not about computerizing your current workflow. It's about re-engineering your workflow to take advantage of the new tools and the capabilities. And to make it, just to put a punctuation on it, last month there was a really brilliant survey done, a report done, that tries to get to whether or not the EHR adoption incentives will result in a positive return on investment for the providers that are taking advantage of these subsidies. And their conclusion is that no, a majority of practices adopting EHR will fail to achieve, in the current incentive program, will fail to achieve a positive return on investment. The average loss to the practice over 5 years will be around $40,000 to $50,000 in expense for adding EHR. And this doesn't even get into the potential loss of productivity from longer work hours to cover the same number of patients. So this is a little bit of a reality check. This particular graph here was in the original partner study in 2005. And they were making a very important point at the beginning of the process, and that is there are 4 curves here. Up at the top, level 1 is a 0 ROI because there's no investments. Let's just continue to use paper. Level 2 is, hey, let's add fax machines. That will show an ROI because we're suddenly more efficient. Level 3 is, let's add EHR. That's the blue line that goes down with a negative ROI because there's a lot of investment and you don't return to 0 yet. And line 3, the dashed red line, is what if we add EHRs and we make them interoperable with all the other EHRs? And the study, the model showed that the only way for adding the technology to achieve a positive ROI was if they could the technology could actually talk to each other rather than adding technology to an existing process. So that's why I brought this up. This is the "You Are Here" slide. We have spent some years now investing heavily, and we've raised the cost of doing business, and we're not ready yet to get our ROI, but we are ready to recognize how quickly we can move to continue to focus on the standards that we need for the data to become interoperable. The last thing I want to take you to take away is that there's a comment period open right now from ONC and CMS for the next policy levers they should focus on with regard to investing in health information technology. So it's open for another week and a half. So I encourage you to take advantage of the opportunity to submit a comment. Thanks.
Turning it over to Rich, I really want Rich to give you a flavor for another tactic and another solution and strategy that he's been deploying in the Inland Empire and surrounding and not surrounding areas as well.
We are essentially we're a hybrid public-private HIE. We provide public HIE services to the communities that we serve. As currently, that's 3 counties, San Bernardino, Riverside, and San Joaquin counties, and that will be growing. It's expected that will be growing pretty dramatically here shortly. And we provide private HIE services. That is, we work with enterprises who are looking to do enterprise HIE implementation, and we provide those services internally. We're also a hybrid in terms of our model. Right now, we have 37 participants. 9 of those are in our live environment. The other 37 are coming up, or the rest are coming up. We provide both an aggregated clinical data repository and a federated approach, and we'll describe the federated approach well. That is the traditional exchange, the movement of data from one source to another. But we also provide a longitudinal patient record environment. So about 90% of our participants send information to our repository, and then that information is available to those docs providing direct patient care within the communities we serve. So currently in our live environment, we have about 1.4 million patients. That represents about 600 beds and about 400 or so docs. Our participation group, which our definition of participant is a group that has signed our agreement, paid their fees, and are in some stage of implementation, represents about 1,500 docs and about 2,500 beds with almost 2 million patients. So our public service area right now covers about 13% of the state. It's about 5 million patients, about 13% of the state in terms of our coverage, which is growing rapidly. I will tell you, just as a high level, our model, our business model is really about growth. I don't believe HIE can be sustainable without growth, and therefore our model is to expand and to grow, not to impede, not to create problems with other environments, but to grow our business and provide services within the various communities that need it. And at the core of that model is our governance and our governing council and our founders, who essentially recognize that HIE is about providing better patient care. It's about treating our patients in our communities, and that is at the heart of everything that we do. So that's kind of a high level. What I really prefer to do, Lori, is to maybe open up for questions and really get an opportunity to address the specific things that I think that most of you might be interested in.
Great, thank you. Also, can you just mention a little bit, because both you and Will have a similar model of going to the various communities for what they need, not just by geography. You'll notice from Will's map back here that he isn't focused on one across the street and connecting the neighbor, but up and down the North Coast. And so can you talk a little bit, Rich, about your strategy? You mentioned Riverside, San Bernardino, and then for those of you who know California, San Joaquin, not adjacent. Can you talk about that a little bit?
So let me, our model is to provide services to whoever needs services. So if a group comes to us and says, Rich, we'd really like to talk to you about doing HIE in our community, small startup HIE, for example, we're willing to work with that group to help them provide those services in their community. And so we've been engaged with many communities across the state related to us assisting them in getting HIE deployed, and primarily us providing the services. So I enjoyed Laura's conversation about an HIE service provider, which is really in many ways what we are, the ability to extend our environment to other communities and to other HIEs who need that kind of service. You know, I got to tell you, launching an HIE is ghastly expensive. We're an Orion Health-based HIE, and so we're converse from Will, who does a lot of more open source kind of work. The actual sort of tier 1 HIE products are very expensive, and therefore being able to sustain the product and be able to sustain the environment requires the flexibility and the creativity around providing the model. I will tell you one other thing, and we're going to talk a little bit about sustainability, but this sort of the holy grail, if you will, of HIE. We started our HIE in Inland Empire with no grant funding. Let me say that again. We started our HIE in Inland Empire with no grant funding. We launched it, we signed our contract, each of our participants paid their fees, we launched it, we went live, we continue to grow and expand. Now, since then we've gotten grants, and I'm sure you heard Dr. Kaiser this morning talk about some of the grants that we've recently received. And those grants are being used specifically for expanding services and making our HIE more viable and more valuable in terms of our value-added capabilities, public health reporting, business intelligence, clinical analytics, patient portals, those kinds of things are all services that we're leveraging those grants to support. So I think that's an important point, and I don't know, and I know Will's been sustainable for a long time, and it's very exciting to be sitting next to Will because he is really one of the grandfathers of HIE in this state. That wasn't an aged shot, by the way.
I just spent all day yesterday with my grandson.
There you go.
And just so you know, it doesn't work for me, because if he's a grandfather and we came in at the same time, that means I'm a grandmother, and that so doesn't work for me.
But I kind of want to point that out. I think the sustainability piece is critical, and I don't believe, and my governance doesn't believe, that sustainability is possible without growth, right? You know, the old business adage, if you're not growing, you're dying, applies to HIE as well as any other business environment. So.